Here we go. We are back with chapter 4, part 4. We are going to have more videos for cardiac because cardiac is bread and butter. I'm hoping a lot of this sounds familiar, and you got it. If it doesn't, shoot me an email. So let's talk about valves. We've got the 4 valves. We've got aortic, pulmonic or pulmonary. We've got tricuspid and mitral. And we can have disorders with these of either stenosis, which is a narrowing, or a hardening of that, so it doesn't move aside as well. If you can imagine, the valves are little flaps. If they are hardened, they don't move aside as well, and it'll cause a stenosis or a narrowing that the blood cannot flow through as it would with just a normal healthy valve. Okay. These causes, it could be cardiac output, could be that they had rheumatoid when they were a child, it could be congenital, the hypertrophy, atherosclerosis deposits. There's a multitude of things that can cause that stenosis. With regurgitation, it's insufficient closure, so blood will backflow. The whole purpose of these valves is to make blood go one way so we don't get a pooling of blood into one of the chambers and it stays there. Okay, so you could read the different causes as well with the regurgitation. So as far as these causes, guys, I'm not going to get too crazy. Your book lists a million causes, it seems, for every single thing. So I'm going to focus more on the form and function of things. There are some that I will point out to you as we go along, but it does get a little crazy. Now, it'll manifest depending on which valve it is located on. And I am putting in your supplemental media a nice review of the valves. And the other thing I like about the review is it shows how the heart pumps through the blood, or through how the blood pumps through the heart very nicely, and how it fills in the atrium, goes to the ventricles, and is pumped out. So why don't you take a minute and go review that video and review the 4 valves. Cardiomyopathy are things that will weaken that myocardium or that heart muscle. It can be acquired or inherited, and it's grouped into dilated, hypertrophic, and restrictive. Dilated is the most common type. This is when we get a large, flabby heart. And the heart may be enlarged, and we think, ooh, that's good, we have more heart muscle. It's gotten stretched out, so it doesn't function as it would in a normal heart. You're going to have a decrease in cardiac output, and you can have blood stagnation into that heart itself. If you get blood stagnation into the heart, you can actually form clots. So risk with higher advancing age in an African American man, there's a list of causes. Hypertension is a great example. Obesity, if the heart is working really hard to pump blood throughout the body. And then they also have atherosclerosis. That's an issue. Coronary artery disease is another issue. Okay. Hypertrophic cardiomyopathy is when the actual walls of the ventricles, more likely the ventricles, will get thick with cardiac muscle. So it's more common in men and those who are sedentary. This can slightly happen with athletes too. You can have some hypertrophy with your heart muscle as an athlete. What we're talking about here is dysfunction. Okay, so hypertension is going to be one of the things that will cause this. The heart is going to work really hard to push the blood out against those thick and roughed arteries. So it will actually increase a little bit in size. Thyroid disease can also cause this. There can be a genetic component as well. And those ventricular walls would become stiff and unable to relax. And the other side note with this is if they can't relax, they can't open enough and let enough blood get back into them. Restrictive cardiomyopathy is caused by rigidity of the ventricles, leading to damage and scarring of the myocardium. So this creates hard tissue that won't relax enough to let enough blood get back into the heart, and then it can't contract as efficiently as a normal heart would either. So you can also have this from hemochromatosis is something we should talk about. That's a good thing to review. If that's not looking familiar, what that means is iron deposition. When you have too much iron, or if you have a disease where you can't process iron appropriately, hemochromatosis is that disease, you can actually start to deposit iron into the tissues of the body. And we like to deposit into the liver and the heart muscle, and this actually will scar the heart muscle. So you get more of a restriction in the ability of the heart to function. It won't be able to contract and relax as properly as it would with a healthy heart. That can also happen with an MI, the scarring from MI, probably SLE, sarcoidosis, obviously cancers would cause it as well. So I don't think that's quite as common as a whole as the other two. So let's practice a little bit. What are these? So here, don't look in your heart or your book at the heart, because this is the example of it here. So let's think here for just a minute. I have normal heart here at the top, just to give you a basis of comparison. So if we were to look at the first one to the right here at the top, we're looking at B. What do you think that might be? Dilated. You got it. How about C? C and D are hard to differentiate between the two of them. Okay, so think for a minute about the actual definition of the cardiomyopathies. I moved them. Okay, hopefully you thought before I messed that up. Hypertrophic, because the walls are going to be thicker in this one. This one almost looks normal, doesn't it? Restrictive. And I would think if we were to get a cadaver of somebody with restrictive cardiomyopathy, it pretty much would look normal. But if you were to cut that heart open compared to a normal heart, it'd be much tougher and thicker to cut through. Electrical alterations of the heart. So these will be your dysrhythmias. This is going to be when that electrical circuit from SA node to AV node, bundle of His, bundle branches, Purkinje fibers through the heart muscle is dysfunctional. And it can be dysfunctional from a multitude of, once again, here we go with all the causes. Obviously, heart disease is going to be a big one, and that's what we'll mostly go with, okay? Now, you could have dysrhythmias that are somewhat normal, right? We can have atrial dysrhythmias that people can live with, albeit not super well at times, but they can live with them. But ventricular dysrhythmias is where it gets a little icky. There can be issues. So these electrical alterations can occur if we have damage to the heart, especially with an MI, or if we throw a clot into the coronary arteries. And the coronary arteries, I just want to explain really briefly. And I'm going to make note to put a picture of the coronary arteries into your supplemental media. The coronary arteries are the arteries that bring blood to the heart. And they come right off the aorta and feed the heart muscle itself, if you don't remember that. I'm sure you all do, but in case you don't. Now, it's important to understand the anatomy of those because they are small blood vessels and they are main blood supply to the heart muscle itself. We don't get blood supply from the inside of the heart. We get it from these coronary arteries. These coronary arteries, if they get blocked, will actually cause ischemia to the heart muscle, which then will cause a myocardial infarction or that tissue death. So that's how that happens, and we'll probably go over this further in the notes. But just as a little side note, I'll go over those coronary arteries with you. Now, back to the electricity of the heart, the electrical of the heart, I mean. So it can manifest in different ways. They can actually feel the dysrhythmia, have palpitations, fluttering sensations, skip beats, maybe fatigue, confused, have dizziness, difficulty breathing, abnormal heart rate. I think that all makes pretty good sense. Now, I did leave diagnosis in here because obviously they want to have an ECG. I love how your book grouped this together. This really helped me. ECGs have never been my strong point. This really helped me to get a better understanding of this. What I did was I took the pictures that are in your book that are on, let's say in chapter 4, about page 88, and I enlarged them so we could look at them together, and I put them over 4 pages. So your book has this broken down into supraventricular rhythms, which are going to be things that will happen above the ventricles. So in the atria, or just at the juncture of the atrioventricular openings, okay, or boundaries. So supraventricular. Sinus bradycardia is going to be less than 60 beats per minute, but a regular heart rate. So sinus rhythm is just slightly slow. This can be in somebody who has really good shape. If somebody is a really good athlete, or is a really good athlete, their heart actually will hypertrophy or grow a little bit, and they pump more blood per pump. So their heart actually beats at a slower rhythm. Of course, this could also be disease processes, but I want you to understand the basic concept that sinus bradycardia is going to be at a slow rate. It's a rather regular rhythm, and it's just that sinus rhythm is a little slow. Sinus tachycardia, on the other hand, is a rate that is specifically above 100 beats per minute. And this is where we get into splitting hairs. To actually define some of these things, you need to know the specific numbers. So sinus bradycardia is less than 60 beats per minute. Sinus tachycardia is greater than 100 beats per minute. It's a regular rhythm. We see this when there's some sort of effect in the atria or that SA node. You can also just have it from anxiety. Generally, people will be fine with this once they get rid of, whatever the issue is, of course, unless it's a pulmonary embolism, right? But this can happen just normally, or if you're really stressed. Now, an atrial flutter is not going to be as normal. This could be indicative of heart failure. This will be a rate that's above 100 beats per minute. And what really stands out here is that you lose that nice P wave, and it's replaced by what they call flutter waves, which have like a sawtooth pattern. So it's almost like you have a P wave and a T wave that are the same height. Okay, so you get a sawtooth pattern. Atrial fibrillation can be with heart failure. This is also present in patients who have an area in their atria that fires as opposed to the SA node. So they have that's called an ectopic foci. So if they have somewhere in their atria that's firing that shouldn't be, and it's taking over for the SA node, they can have this atrial fibrillation. It is irregular. So this is an irregular beat greater than 100 beats per minute. Okay, P waves can't be found on that, and it can be a byproduct of many other diseases. So the next slide. So we are looking at, we did atrial fibrillation. Oh, paroxysmal supraventricular tachycardia. What happens is there'll be a sudden outburst of heartbeats, and that will be greater than 100 beats per minute. This could be an abnormality of the conduction system. It can be stress. It could be too much coffee. It could be that person has had a lot of cocaine. For some reason, they'll have this sudden outburst or grouping of regular heart rate that's above 100 beats per minute. I think that's a good side note. Junctional rhythm. The AV node is setting the rhythm. So with this, the atrial rate is going to be less than 60 beats per minute because the SA node is going to set it 60 to 100 beats per minute. If the AV node is setting it, it's going to be less than 60, okay, be 40 to 60. This could happen with some sort of damage to the wall itself of the myocardium. And I don't think you can see. There we go. okay? That AV node is setting the rhythm. When I ask you questions about these electrical events, it's going to be these things that I've highlighted here. You know, I want you to know the major groupings, supraventricular versus ventricular. I want you to know sudden outburst, where the large letters are, okay? So I know there's a lot on here. Focus on the big things that I'm explaining to you for these, okay? So ventricular rhythms are in the ventricles. We'll talk about a PVC first, is an extra heartbeat from the ventricles. And you could see in the middle there, there'll be an extra heartbeat with the ventricles. And we know it's ventricular because it looks like a QRS complex. It's pretty large. And that resetting of it takes a pretty big dip as well. And then it reestablishes with that normal P wave, QRS complex, and then T wave. So you get that PVC where you get that nice spike. It's not nice, you know what I mean? Nice spike, large spike, let's put it that way, of a ventricular contraction, then it resets to the normal rhythm. Ventricular tachycardia is just going crazy. Large, quick, fast spikes and resettings. We'll see this in an MI, would be a good thing to know. And then if that progresses, we can get ventricular fibrillation where it really starts to go nuts. And there is no real rhythm or regularity to these contractions. If you were to open up the chest plate, the heart would look like a bag of worms, is what they call it. And obviously you'll need to reset that if that patient's going to make it. So, heart blocks. Heart blocks are when signals are blocked between the atria and the ventricles, and the ventricles create their own beats. I found this a little confusing, so guess what I found? But one more thing I just want to explain. So it goes first degree to third degree. First degree is the least intense, and people can live with it. It's seen in healthy people even. Second degree is more intense. There's more issues. There's 2 levels of that. And then third degree, obviously, can be an issue if we move. There we go. Is complete heart block, where the atria and the ventricles are contracting completely separately. And you could see on the EKG, they have listed there the second from the bottom. Things are just kind of all over the board there. You don't have that regular contraction of the atria and then the ventricles. Finally, before I move on to my neat little mnemonic that I found, there's asystole. A is without heart rate, obviously. This is not good news for this patient. Nursing mnemonics and tips, the heart block pump. So this deals with the heart blocks where we have that block between the atria and the ventricular electrical systems talking to each other. This is what I want you to remember from them. First of all, first degree is the least intense. Third degree is very intense where they're firing separately. So if the R is far from P, then you have first degree. So that means that the P wave and the R wave tend to be a little bit further apart. If it continues on and you have a longer and longer separation of the heartbeats there and the contractions, then so longer drop, then you have a wink back, which is your Mobitz 1. If some P's don't get through, then you have Mobitz 2. So you don't always have a P wave before you have the QRS complex. And then if it's all over the place, if your P's and Q's don't agree, then you have a third degree. So I hope that helps you a little bit. Electrical activity of the heart has always been a challenge to teach and to understand. I hope some of this clarifies it. If you have any questions, please let me know, of course, as always. And question time. A patient with dysrhythmia will always present with an increase in heartbeats per minute. True or false? Okay, moving on. Heart failure. Heart failure would be inadequate pumping, which would lead to obviously a decrease in output, an increase in preload because you're bringing blood back into the heart and it's not getting out. congenital heart defects, myocardial infarction, heart valve disease, dysrhythmias, a multitude of things can cause these. So the sympathetic nervous system will kick in, heart rate will go up, they'll try to increase their blood pressure, they start to feel very stressed, very sweaty, very clammy. They'll activate that renin-angiotensin-aldosterone system, retaining the salt, retaining water. Ventricular hypertrophy, the ventricles will try to grow to try to compensate for the decrease in blood that they're pumping out. They'll try to pump more blood per pump. So it can help at first, but obviously it creates a very vicious cycle that perpetuates that heart failure. So types of heart failure, your book talks about systolic, which is going to be decreasing contractility. Diastolic will be decreased filling, and then mixed dysfunction. But what I really want to get into is right versus left heart failure. So you have the left side of the heart and you have the right side of the heart. If you get one side failing as opposed to the other. Now, in general, if somebody is in a condition where their heart is failing, the whole heart is probably going to fail. But if we were to look at this, right versus left, right-sided failure is when blood backs up into the peripheral circulation. So the right side of the heart is starting to fail. It can't pump the blood to the lungs. It'll pull back into the right side of the heart and then back into the superior and inferior vena cava. That'll cause systemic edema, okay, and weight gain. So this could be your heart's failing, could be your lungs are failing, could be the left side is failing, could be a valve. Left-sided is when, obviously, the left side of the heart starts to fail. Blood will back up into the left side of the heart, back into the lungs. Because it's not getting out of the left side of the heart into the system, it'll back up into the lungs, causing pulmonary congestion, difficulty breathing, and somebody who just doesn't feel like doing anything. So obviously left-sided damage will cause that damage to the aorta, damage to the mitral valve, because that's on the left side. Okay, so I would know the structures that are on the left and the right side because those can cause left or right-sided failure. But as I said, for the most part, if somebody's having a failing heart, it's probably both-sided. Here is this chart for you. Once again, if this helps you to remember things, that's great. Otherwise, go by my notes because that's what I'll test you by. And here's a picture. So this shows at the top, and I kind of blew this up a little bit. You could see it in your book. You could see the whole picture in your book. I find this is a little bit confusing, but this shows the steps at the top there. So left ventricle weakens, cannot empty, decreased cardiac output to the system, decreased renal blood flow, stimulates renin-angiotensin, backup of blood into the pulmonary vein, high pressure in pulmonary capillaries leads to pulmonary congestion or edema. I think it breaks it down pretty nicely. Right-sided. Right ventricle weakens, decreased cardiac output to the system, decreased renal blood flow stimulates renin-angiotensin, backup of blood in the systemic veins. It'll go into the superior and the inferior vena cavas. That'll increase that venous pressure. That'll push fluid back out into the tissues, causing edema. It'll also cause liver into the liver and the abdominal organs. And the reason I point that out is because you can get a distension of the veins on the surface of the abdomen as well as into the esophagus. You've probably dealt with that before. Very high venous pressure, so distended neck veins and cerebral edema can happen. You can also have, like I said, distension into the abdominal veins as well as the veins around the esophagus. All right, that is it for this video. If you have any questions, please shoot me an email and I'll see you in the next video.